Thank you, Prof. Actually, it is not actually a crossfire between me and my dear friend Dr. Tara. It is another philosophy of the implant design. And one of my friends, when talk about the title, asked me, this means that if you have a size 5, it's okay to use a size 7. We are talking a different scenario about the radii. And this is the idea of Dr. Ayman Abid. The aim of total knee arthroplasty to reduce the pain, restore the function, and improve the quality of life. At the end, we need to have a painless total knee replacement, stable, with a freedom of movement. But actually, if we don't have a serious complication, still we have a significant number of patients, unfortunately, not satisfied by the results. And there is a big difference between a serious complication and dissatisfaction. Serious complication is low. It is about 3.7 at 5 years, 6.8 at 16 years. But we have more than 10 to 20% of patients still unsatisfied by their intercom. And there is growing interest in publications who are concerning about the patient satisfaction. And most of the papers encounter that satisfaction range between 10% up to 30 or 40% of the patients. And we have some sort of predictors of patient satisfaction or dissatisfaction in the preoperative and the postoperative. And the most predictor of satisfaction of the patient, if your patient goes through the journey of the total knee without pain, without complication, without readmission, and reported high patient-reported function with a very good range of motion, this is a very good predictors of highly patient satisfaction. Also, if the patient with a high grade of osteoarthritis, with older age and male and good implant, this is a predictor of satisfaction. How to improve our patient satisfaction? We have 3 pillars to improve the satisfaction. Either through perioperative management, changing the alignment concept, which is covered in the last session, and evolution and the processes. As regard our techniques, we have the multimodal approach for satisfy our patient in the preoperative management to improve the pain management, and there is a dramatic change in our practice to make the total knee less pain during the early postoperative. We have the mini invasive surgery to decrease the pain and improve the rehab postoperative, and blood management in the perioperative time to decrease the need for blood transfusion in the postoperative. And patient satisfaction, we have a change in the alignment concept as discussed before, and the change from the mechanical alignment to the anatomical and the kinematic, and all of this to restore the normal anatomy of the patient and increase the satisfaction of our patient. What about the processes of evolution and the physiological matching? And our question in this lecture, does the femoral sagittal radius and the curvature affect the kinematics and the outcome of total knee arthroplasty? Yes, of course, because our knees, they don't have a single radius either on the medial femoral condyle or on the lateral femoral condyle. On the medial femoral condyle, we have a 4 or 5 radii in the sagittal plane of the medial femoral condyle. We have anterior facet, extension facet with radii about 32 millimeters. We have the flexion about 22, which is less, and the posterior facet, which is a smaller radius. So we have graduated decreased radius through the surface of the condyles. And the lateral femoral condyles not have reduced the radius like the medial one. And both have a circular in the posterior part of the condyles. So of course, by logic, the first to be introduced in the design of the femoral component in the early evolution total knee in 1971 is to start with the multi-radii, sagittal radii in the total knee replacement to imitate the normal anatomy of the femur, and start with the multiple radius. So the multiple radius is still widely used, trying to imitate the normal anatomy on the sagittal plane of the femoral condyles with a large distal radius in extension, and it's responsible for the stability in extension during the gait and minor degree of flexion, and with a smaller radius for the rotational freedom in flexion and to allow a roll back. And this multi-radius, it is already introduced in many of the designs we are already using and still using till now in Zimmer Nexogen, BFC and Debui, Biomet, Vanguard, and Persona, and Smith and Nephew. And this is how the sagittal difference between the extension and the flexion, and was designed to reduce the accepted J-shaped radius of the nature femoral condyle curvature. But the problem is that we have a transition between distinct radii with abrupt change between the large radii in extension to the flexion. And this may introduce some sort of mid-flexion instability. And mid-flexion instability, one of the major causes of patient dissatisfaction and usually complaining about walking uphill and downhill during stair climbing and during getting up from the chair. To reduce this sense of instability, they invent the mechanism of the cam and post mechanism, the posterior stabilized using the post cam mechanism, which is designed to provide the intrinsic stability through the mid-flexion. So if we have any problem in gap balancing techniques during our surgical techniques with non-functioning probably of the cam post mechanism, this will end in paradoxical anterior femoral sliding in multi-sagittal designs implants with mid-flexion instability. Again, they wanted to shift to another theory with the single radius femoral components. They are trying to convert the knee into a pure mechanical processes. We don't need for the abrupt transition from the extension to the flexion and the mid-flexion instability. So the single radius design has a uniform radius of curvature from 10 to 110 flexion, which give advantage to the extensor moment arm to improve the mechanical stability and maintain the equidistant conversion about the entire range of motion. But we need to prove this to use a relatively flat insert and not highly conformed insert to accommodate the internal and external rotation. Because if you are using a single radius, we cannot use highly conformed plastic insert, and we need to use more flat to allow some sort of rotation. And it is thought to be decrease the mid-flexion instability by using a single radius curvature, and this is applied in the medial pivot and the striker triathlon. The concept of single radius femoral component was based in principle that the superficial medial collateral ligament isometric throughout the range of motion with uniform flexion arc centered about the transepicondylar axis, with less conforming polyethylene is required to allow the femoral root pad. But this theoretical advantage of single radius over the multiple radius does improve the better functional outcomes. It is a debatable issue and no evidence and complete conflict between the results when comparing between them. They are trying to go back for the multi-radius but with gradually reducing the radius design without abrupt change in the radius between extension and flexion, and decreasing the incidence of mid-flexion instability and increasing the conformity between the plastic insert and the femur. And this is applied for the new designs by Debui in Aton total knee arthroplasty, and this is increase the anteroposterior stability and decreasing the incidence of paradoxical anterior movement. And this gradually reducing radius provide high conformity and stability in lower friction angle comparing with the radii design. And the steady decrease to reduce the conformity and the gradual decrease in the radii increase the mobility in high flexion without paradoxical anterior translation. The medial pivot total knee, it is one of the modification and it is a single radius design, but the modification here in the plastic insert and the articulation part with highly conformed medial side and less conformed the lateral side and the flat plastic insert. So allow the medial side for the rolling and rotation and translation on the lateral side. And the lateral femoral condyle usually translate by 15 millimeters, while the medial side as a ball and socket constrained part moved only by 1.5 millimeter with the resultant movement about rotational about 30 degree. Again, the results from the literature is conflicting. Some studies demonstrated that the stability of the single radius or medial pivot compared to the multi-radius, and again maybe more than. Now we are the 7 radii knee with multi-radius femoral component design. Most of the multi-radius component before is about 3 radii or 5 radii. Now we have the 7 radii with a large radii to inhibit the significant rollback in normal gait. 1 minute, please. So this 7 tangential radii was incorporated with the large radii to inhibit the significant rollback in the normal gait, with a smaller radii greater rollback as flexion increase into deep and full flexion with a smooth transition across the entire femoral condyle profile. 7 radial knee, it is a thinner component, bone preserving, and this is the difference between the cuts in the multi-direction or single radius and the 7 radii, and accommodate a deep flexion and improve the patellofemoral kinematics with less posterior bone cut with the high flexion. Finally, in conclusion, when you are comparing the functional outcome in randomized controlled study, insufficient evidence to support the single radius, the multiple radius, or the medial pivot or graduated radius over the traditional multi-radius design. Not translated into a better clinical outcome. Early result of the graduated radius or the 7 radii show better knee kinematics and clinical outcomes, but still we need a more randomized study and more patients to prove this. Thank you. Thank you very much.